Thank you very much to the organizers. It's a real pleasure to be here and have the opportunity to share what we've been working on, and really exciting to hear all of the different efforts and listen to people being brought together in this way. So thank you very much. I don't have any relevant financial disclosures. And similar to Dr. Kaza, per the CME guidelines, some of the learning objectives that I hope to accomplish today are to review the historical experience with EP mapping, looking at the electrical signals, to present our institutional experience with mapping in this modern era, and then to also explore areas of research and ways that we might be able to further this approach and this technique going forwards. So we've heard a lot today already about how surgeons approach the conduction system in the operating room, primarily starting with the work of many pathologists, including Dr. Anderson that we were just speaking about, using this this series of pathological specimens to learn about where we anticipate the conduction to be. This generates a sort of rule-based approach where in corrected transposition, for example, as we just saw with Dr. Kaza, that we're looking at we're anticipating that the conduction is going to be superior, that in a canal defect, we're anticipating that there will be an inferior displacement. But it is rule-based and it's not patient-specific. And what I'm going to present to you today is a slightly different approach, the electrical approach, which might be motivated by specific lesions where we have a high risk of heart block, or we know that that's a difficulty that's encountered in that surgical repair, but it's very patient-specific and looking at the conditions in front of you in the operating room rather than applying a rule to this. And it's a functional rather than rule-based approach, where, or rather than an anatomic necessarily based approach, where we're looking at the electrical signaling from that location. And so this is an example in the lower right-hand corner of what the electrograms look like in comparison to a surface-based ECG. And I think the histological approach and some of the other methods that I'm looking forward to learning about even more today kind of offer the anatomic approach, but at a patient-specific level. So I think those are really exciting as well and sort of analogous in many ways to what we're doing. As Dr. Del Nido alluded to earlier, this really was an area of significant research in the 1970s primarily. One of the earliest papers looking at electrocardiographic techniques published in Archives of Surgery in 1970 with Dr. Kaiser as the lead author from New York, I believe this group is at Columbia, looked at a number of different, the use of electrical mapping in the repair of a number of different common forms of congenital heart disease, as illustrated in the upper right here. This is the technology that they were using here at the bottom right. The leftward plaque is a plaque that was sutured with electrodes to the heart near the sinoatrial node and used to pace the heart at a constant rate. And the probe on the right-hand side has 3 electrodes that are oriented so that they can capture orthogonal directions of electrical vectors. And that probe was what they used in all of these cases in order to look at the conduction system. This particular paper was more of a descriptive approach and didn't really get into much as far as how this affected the outcome and decreased the rate, but they sort of presented this as a technique and noted that this was the rates of heart block were so significant, and the morbidity, as we saw with Dr. Del Nido, was in the 30% range if you got heart block. So it was sort of a conceptual approach to start. Members of this group went on to do a broader look at this and look at a larger group of patients. This study from Dr. Krongrad and colleagues from the first one, published in 1974 in JTCVS, demonstrated that in 80 patients with congenital heart disease, they performed electrical mapping using those same techniques and tools that I showed you earlier. They said that none of the patients that they mapped developed complete heart block, but they did note that a significant percentage had transient AV block associated with placing the probe in the area and doing rigorous mapping in that area. So something to keep in mind and be aware of as a possibility. And this group expanded with Dr. McDonald Dick, who was an early electrophysiologist here at Boston Children's, who went down to Columbia to do some work with this group and learn this technique. And they looked at the precision of doing this type of mapping operating room. With this particular study, they looked at the use of a 2x6 grid of electrodes that was placed near the compact node and the penetrating His bundle and analyze the signals that they saw from these 6 different bipolar electrograms that they were able to obtain. And they were looking both at the amplitude of the signal that they could measure, as well as how it varied across this region that they were looking at. In particular, they wanted to look at what the decay was like, where they could find the maximum electrogram, and then how they would anticipate the signal to change as you moved further beyond. And I think what the 2 of the main considerations they found here is, one, that within 3 millimeters from the His bundle, you start to have almost no, you can almost not obtain a His signal. So it's within a sort of 3 millimeter range on either side of the central maximal electrogram that you can measure this. They also noted a fair amount of variability in the amplitude of the signal that they were actually able to obtain. These were repairs being undertaken slightly later in life than we often do now. And so there may have been already pre-existing myocardial scar from times, prolonged time of cyanosis and other things. But they wondered about sort of from patient to patient, what conditions might affect that. And Dr. Dick, when he came back to Children's and started implementing this here with Dr. Castaneda and Dr. Norwood, described our experience here at Boston in 47 patients in whom this technique was applied. All the patients had congenital heart disease, and many of whom had canals. And in 80%, they were able to identify the location of conduction at the time of surgery. They had a rate of heart block of 8% in that cohort, which was quite good for that era. And the numbers don't quite add up in their paper, but in 4 out of 10 patients, they could not identify the conduction system, and they had heart block in those patients, suggesting that the ability for the electrophysiologists or cardiologists at that time and the surgeons to look and have an understanding of where the conduction system was did appear to have an impact on the ability to avoid heart block. There were a number of further studies at that time, smaller experiences from different areas in the country that looked at specific defects and tried to use this technique not just to avoid the conduction tissue at the time of that repair, but also to further our understanding of where the conduction system is likely to be in these lesions, and adding to the body of knowledge that was already being generated from anatomic studies. And I think what's notable when you read through these and very interesting is that many of the themes that the authors comment on are things that we've experienced in our own practice here, noting that despite anticipating and having the conduction go superiorly or inferiorly, there's marked variability patient to patient, and that just knowing the rules didn't sort of capture the entire picture of each patient in front of you. And furthermore, I thought it was very interesting to read this paper from Dr. Wolf and Dr. Alley from the Annals of Thoracic Surgery in 77, where they noted that they would make an anatomic sketch at the table in order to facilitate communication between the cardiologist and the surgeon. And I'll show you how that sort of plays into what we've been working on in a bit. Furthermore, efforts by Dr. Siegel and colleagues had been made at this time to automate the obtaining this information. So rather than relying on communication between a physician looking at an oscilloscope at the time and the electrical signal from that, having a circuit that they diagrammed down here in the lower right, where they actually time gated from the atrial electrogram or the PR interval on the surface ECG, the P wave on the surface ECG, and anticipated a window in which they would think that a His bundle would occur, and then use that and other characteristics to sound an audible tone when the surgeon moved over the area of interest. So a way to potentially have this be contained within the surgical field rather than relying on an extra operator. So really, with all this research, the question is, why did this fall out of favor? Why did we stop doing this? And I've asked myself a lot this question over the past couple of years, and I actually had the opportunity to speak with Dr. Dick at Heart Rhythm Society a couple of weeks ago, which was wonderful, to ask him this question directly. And he agreed that it was a combination of factors. I think that the Increased knowledge of the lesion-specific anatomy made us confident, made surgeons at the time feel more confident about where to expect this, and thought that perhaps we don't really need to do this anymore, that this was taking time from the operation. It wasn't of value as much as we've made all these gains. Also, I think the pacemaker technology was improving. There was less morbidity associated with getting heart block because you had pacemaker options, and they could be implanted even in smaller children. And then finally, this was something that Dr. Dick pointed me to, the techniques of operative repair, especially in neonates, shifted and went towards deep hypothermic circulatory arrest. And so the process and the availability of a beating heart to examine this on changed, and so it just sort of fell out of favor. It's the best that I can put together after the fact. So why do I think it's important now? As Dr. Kaza and others have alluded to, we're attempting more and more complex repairs. We're no longer satisfied to just say that this heart is too challenging to septate. We're going to try to make 2 ventricles where perhaps there was only 1. We're not necessarily going to commit patients to a single ventricle palliation strategy. So our biventricular repair program at Children's and at other places around the world has really taken off and become a critical component of what we do and what our surgeons do. And so we've already gone through these cartoons, and I think gone through the anatomy. In addition to the high-risk anatomy and the variability and complexity of these patients from an anatomical standpoint, the operative techniques that are needed in order to effect this sort of repair are some of the highest risk. When you look through, STS and other outcomes, they're all the hardest, or the operations or components of operations that are associated with heart block. And so I think those 2 things are significant, and published reports have shown that in some of these complex, especially heterotaxy patients, these complex repairs, the rates of AV block are back up into the 15 to some 25% range, and that's really unacceptable for us in the current era. We've already gone through some of the burden of chronic pacing, increased mortality, the risk for cardiomyopathy associated with chronic ventricular pacing, the need for reintervention for devices, the risk of coronary compression for epicardial leads, which one of my colleagues, Dr. Ma, reported, and then costs associated with pacing over the time, which Dr. Kaza and his group produced, and really are quite substantial. So looking back at why they moved away from it, why I think it's important now, we're doing harder surgeries, more complex things, and we need this now because what we're doing surgically has changed. Even though our pacemakers are better than they were in 1974, they leave a lot to be desired, and they certainly aren't as good as the native conduction system. And finally, although this technique is different than what we do with most of these surgeries being done on cross-clamp, it can be done in concert, and I'd like to just demonstrate how to do that. And finally, because I believe that a patient-specific approach really is the highest standard of care here, and that not using generalizations, just as we would always obtain an echocardiogram or an MRI for the individual patient that we're taking to the operating room. I think the knowledge of the individual's conduction system probably has importance that we haven't emphasized quite as much in past decades. All right, so I will move on to talk about our current workflow. This is an intraoperative video that looks at the catheter that we're currently using to obtain these electrical signals. The approach is that the surgeon cannulates and goes on bypass at the start of the operation. The heart is fibrillated and then opened via an atriotomy or ventriculotomy, depending on the approach that the surgeon wants to take. Drop suckers are placed across the AV valves, and the heart is then defibrillated back to normal sinus rhythm only once empty. We tend to do this at temperatures around 32 to 34 degrees Celsius, so not cooled all the way down, because at lower temperatures we were finding spontaneous heart block, even before touching the heart with the catheter. Mapping is then performed, and then at the end of mapping, the heart is arrested and the surgery is continued. So the heart is never closed up with air in it. And just to specifically talk about the beating heart strategy and risk of air embolus, because that's something that comes up a lot. The heart is always fibrillated before opening while on bypass, and then is emptied and only defibrillated back to sinus rhythm once the heart is completely empty. And then after the mapping is completed, the heart's again fibrillated. So again, there's no opportunity for that air to be ejected. The catheter that we're using is a little different than the probe that I showed you before. This is an EP catheter from the EP lab space, so used in a transvenous approach and designed for use in adults. The electrodes is a 4x4 grid. There's no reason that you have to use this particular catheter. We have, and I'll show you, a couple of reasons why this is particularly helpful, I think, and was a critical piece of us developing this technique. It allows for bipolar reporting in orthogonal planes so that you're not missing, if your nurse is not aligned with the his bundle direction, you don't miss those signals, you're able to capture that. And the other thing is that it really facilitates the communication to the surgical team. And the idea to use this catheter was my colleague, Dr. Ted O'Leary's, and I just think it really allows for the surgeon to cover a fair bit of ground quickly and effective communication. We kind of joke that it's like playing Battleship because we're giving out coordinates and ideally not sinking the battleship, i.e. not getting conduction, but we're basically talking back and forth, communicating these coordinates to one another. And the mapping is done with just a standard EP lab recording system. This is an example of what the signals look like. You can see we have a number of different bipolar electrograms that are displayed here. At the very top line is AVF. It's one of the surface lead ECGs. It's a little bit low amplitude, but there's a P wave and a QRS that you can see. And the signals that we see here, the first one is the atrial electrical signal. The second is the signal of the his bundle electrogram. And then the third one is the ventricular electrogram. And this is something that, we have a catheter when we do EP studies, we have a catheter that sits at the his bundle and looks at this throughout our cases so that we're not causing injury there. But that is how we display these in the operating room. I'll show you this brief, I'll show you this video, hopefully. So this is the surgeon marking the catheter. These are designed to be used with electroanatomic mapping where you don't need to mark externally. And then I'll look hard. Not sure the audio is going to be quite loud enough, especially for those joining on Zoom. But effectively, it's communication back and forth, where the electrophysiologist is scanning through to try to see where that biggest signal is. And the surgeon is relaying where they are anatomically. They're sort of interpreting what I'm telling them. And then what you can't hear Dr. Amani saying is that he's sort of suggesting to Dr. Fines a way to kind of cheat the sutures or the patch placement away from that. And then you saw them actually marking with a catheter or with a pen where they're actually seeing the conductions, but they have a mark for later on in the case. So the 3D models that our cardiac engineering team has been working on and generating, and that our engineer, Jocelyn Davey, does painstakingly for each of our cases, offer us a way to communicate between the surgeon and the electrophysiologist. So harkening back to the drawing at the operating room table that Dr. Wolf describes, these provide a really beautiful three-dimensional view of the anatomy and also where we're finding conduction. And over the course of the mapping that we've done, we've generated models for pretty much each patient that we've mapped and marked these. And so hopefully, sort of speaking to what Dr. Sanders said about that we need more data, we're hoping that this will be able to provide some more data in some of these very complex lesions that might allow us some ability to create predictive algorithms that may not be perfect, but may give surgeons a sense for preoperative planning of where they might anticipate this in different conduction, in different congenital heart disease. This is a graph of our work in this region over the past 2 years. We've mapped 180 cases now, and we have analyzed data up through 147 patients, which I'll present here. The majority of these are BIV completions, and some of them are BIV staging, so getting a sense of where the conduction is located as we do preliminary efforts to get the heart ready for a full BIV repair. And then we've also used it for complex VSDs or complex septal anatomies, as well as mitral and tricuspid valve replacements for repairs. We've been able to identify the his bundle in about 95% of these patients, 140 of the 147, and the median mapping time is 6 minutes. And I'd say that checks out with just my practice doing this. It's not much more than that from the time that we defibrillate, start mapping, the surgeon being completed and moving on to fibrillating back again. We have noted some discordance with what we've predicted. So thinking about the ventricular looping here, these 40 patients, this means that in these patients, they were L-looped and we thought the conduction was going to be superior, but in fact it was inferior. And then our current rate of heart block is right around 8% in the cohort as a whole, 13 patients out of this 147. So still work to do, but I think the more we do, the more we'll learn and understand how we can adjust the way that the surgeons do their repairs or provide them more granular data of how to do this. Most kids, the median age is just around 2 years old and around 11 kilos. And I won't go into too much, but just mention that 43 of these patients had heterotaxy. So we have a relatively high percentage of heterotaxy that we mapped, about 30%. This is just briefly looking by lesion or by specific anatomic subset. I'm sorry, this is a little bit hard to see probably. The percentage of in that particular category that have had heart block. So we've had some that I think we've made a lot of headway in. Levocardia, D-looped hearts tend to be relatively low, and some success with the mitral valve repairs or replacements. The group that I think we've made the biggest impact in is heterotaxy. I believe we only have one patient with heterotaxy that's had heart block that has had mapping. So I think that's a significant signal. I don't have all the numbers yet, but I think that really speaks to how variable the conduction is in heterotaxy and how these different rule-based approaches kind of collide and you don't know which one to trust. So I think that may be really particularly helpful in that group. Areas that we still need a lot of work, looped hearts, the susceptibility, I think, of the conduction system and that anatomy has yet to be fully understood exactly why that happens. And I'm not sure that mapping will be enough to totally eliminate that risk. And then straddling tricuspid valves has also been a major problem that continue to have a very high risk of heart block. I want to put a plug in for my colleague, Dr. Fines, who will be presenting some of this work tomorrow at the AATS plenary session tomorrow afternoon in terms of when to expect the unexpected in cardiac surgery. And then briefly touch on some of the future directions that I see us being able to take this as we go forward. So we're hoping to develop better tools that might let this be a practice that moves beyond just complex biventricular repairs, but it becomes more mainstream so that even in patients who have just simple lesions, or relatively simple lesions like VSDs or tetralogy of Fallot, who do still get conduction injury, whether it's heart block or right bundle branch block, looking at the development of a highly viscoelastic, flexible microelectrode array with, this is a group at the Weiss Institute that has been working on this type of technology and a mock-up that Jocelyn made for us, looking at how we might kind of recreate what we're doing with the grid and with this enhanced flexibility, perhaps on the end of a probe. We're also looking at how we can leverage technology from other fields. Neurosurgery, as you were alluding to, has a lot of work in the electrical field, and these are grids and strips from neurosurgery for epilepsy surgery to look at where the epileptic foci are located that are implanted on the surface of the brain and sometimes left there for a period of time. And could we use this technology and customize it for use in the heart and create different designs and different configurations that would be more suited to the size and the application that we're using it for, rather than this grid catheter designed for adult BP. We're also looking at how we might integrate some of the technology that we use in the EP lab, electroanatomic mapping, to create an electrical activation, noting the His bundle and how electricity travels with time across the heart. And we've tried some efforts at doing electroanatomic mapping down in the OR. This is integrating one of the 3D models into the Abbott system, the electroanatomic system. It's not a perfect fit quite yet. There are some issues. These electroanatomic mapping is generally done either with a magnetic-based approach, a magnetic field, or an impedance-based approach. The impedance-based approach is dependent on the catheter being in a blood pool. The magnetic approach, we found some issues with even bringing the magnet down to the OR, distortion of the magnetic field with all the different metal surgical instruments that are being used to retract the pericardium and open the chest so that there's adequate visualization. And then furthermore, trying to integrate the beautiful, highly complex models that our team makes with the fiducials in the heart and making sure that we actually are aligning things correctly and that it's not just kind of creating a cartoon. We have some work going on thinking about that same, like Dr. Siegel's work had shown, automating and machine learning to identify the hiss, so that you would get like a metal detector on the beach, you would get a little tone when you come close to the hiss bundle. So we're working on some of the preliminary algorithms for that as well. And I think just to mention that there are a few potential applications of this beyond just looking for the hiss bundle. I think there's areas for improvement that we can harness here in thinking about how to incorporate hiss bundle specific pacing to our practice in congenital heart surgery. So mapping out the hiss bundle, perhaps stimulating it distal to the point of injury, and then picking a spot to put a lead in to use this as an area of active research and where the adult EP field is really trying to go. And then furthermore, thinking about how we might use this technology to improve our placement of epicardial leads for either CRT or just epicardial pacemaker placement to find a spot without having to move the lead around many different locations before we find an acceptable threshold. And then finally, how could we use this and incorporate this into performing more effective maze procedures for atrial arrhythmia surgery? So just by way of conclusion, I do think that intraoperative EP mapping has a future within congenital heart surgery. I'm obviously a little bit biased, but I think that we have the possibility of providing functional data about where the hiss bundle is located and where it's activating. And we have some promising early results, definitely still work to be done. I also think it will integrate or potentially integrate with other forms of identification that we're talking about today, like the histological approach, that perhaps you first start by honing in on the area, by finding the electrical signal, and then perform the more detailed confocal microscopy or mapping to really map it out when the heart is arrested. That if we continue to push on developing better tools for this, that we hopefully will lead to better outcomes for many different patients, and that knowledge and the data that we're acquiring will hopefully also allow us to use some of this in preoperative anticipatory planning and counseling for families. So I just want to thank again the organizers for the opportunity to speak, and my team, especially Dr. Fines from cardiac surgery, Dr. O'Leary from EP, and Jocelyn Davey from engineering team. Thank you very much.